with our session. Okay, if Ramya is there, before that, Ranjit, can you please enable chat for all?
Hi, good evening. I'm here.
Good evening. Yeah.
Yeah. So there's an 8-year-old child who was first evaluated Gulbarga, and recently only I have started seeing him like for past 1 week. So 4 months ago in October, this child presented with fever for 1 week duration, and then some dull activity for a week time. That time they didn't have any neurological issues, but since the child's hair is in different color and they have a history of one sibling death at 6 years of age with similar hair, the parents only wanted a neurologist to see. Then Dr. Arundhati Patla seen, and she suspected Griscelli syndrome based on the phenotype. A week later, the child presented with some ataxic features. That time, a scan was done. I have not seen the films, but Dr. Nihaal is aware of them. And then they were thinking in lines of query some granulomatous disease. So TB was the first in line. So though gene expert was negative, CSF was also almost normal. 10 cells and lymphocytes, protein and sugar was normal. So ATT was started, but the child with steroids was started, and the child improved for probably a week's time, and then again started deteriorating. So subacutely till 4 months, till a week ago, it has become very severe that he was unable to walk, he was unable to, severe cerebellar ataxic signs were present. In a stage there. At this stage, I have seen the kid, and we got couple of MRIs done. One at the time of admission, one yesterday, because he had one episode of seizure which was never there before, which was the right focal, and then this child also had left hemiparesis. So to rule out stroke, we had to do a repeat MRI. So this is the main this one.
Okay. All right. I think
And
I don't have the.
just to clear, the child doesn't have any previous infections, and then the child doesn't have any developmental delay. He's well going to school. He has two more siblings with who are normal with no such phenotype. One, the child sister who died at 6 years of age had a similar phenotype with that hair, gray color hair, silvery gray hair, and then also had jaundice at 2 years, which the child recovered. But at 6 years, this child had a very severe abdominal distension, severe jaundice, and then succumbed to death.
Okay. I don't think I have the most recent one, but I have two scans. One was done, I think, initially in Gulbarga when Dr. Arundhati was taking care of the child. So the initial scans, we have the flares on top over here, and you can appreciate some multifocal lesions, especially in the left parietal lobe, small focal abnormality out there in the right frontal subcortical region. Some periventricular abnormalities, not very bright, but you can appreciate that there are some hazy changes out there. In the cerebellum and the brainstem, again, you can appreciate some focal pair hyperintensities, the middle cerebral peduncles, the bilateral hemispheres out there. On the stat sequence, you can appreciate that the corpus callosum is edematous, or there's hyperintense changes out there. And then post-contrast, there was nodular enhancement of that lesion in the left parietal lobe. Some again continuation of that lesion out here in the subcortical regions. There were bilateral optic nerve enhancement in the intraclavicular and the orbital segments. This is the SAG contrast sequence, no abnormal enhancement in especially the pituitary stalk, important to look for infiltrative disorders. So at that time, the clinical suspicion, I think, was raised of tuberculosis, but I did not think it was typical of tuberculosis. And we raised the possibility of systemic infections, and HLH also was, I think, kept in the differentials, but wasn't aware of the skin and hair changes for the child. This is the follow-up scan done on Feb 9th, and you can see there is progression in the lesions, white matter changes, confluent abnormalities, almost like a demyelinating leukodystrophy out there. Some myelin sparing zones, but you can see the confluent abnormalities in the bilateral hemispheres. And also, there is a progression in the infratemporal abnormalities. The brainstem and the cerebral abnormalities have these parental changes. You can also appreciate the changes have progressed in the corpus callosum as compared to the prior study. So overall, this features we thought was okay. We have contrast. Yeah, contrast. I did not appreciate any significant parenchymal enhancement. Again, optic nerves demonstrate some degree of enhancement. Appreciate better on the coronal sequences. At that point, I thought the changes were. I mean, now given the child had these additional skin changes, or you are aware of these hair changes, possibility of HLH related Griscelli syndrome. The follow-up scan, I think I have not put it up. The one most recently, there were no infarcts per se, but there were some areas of subcortical diffusion changes in the frontal and parietal regions. So those are the very main findings. And then I think, yeah, Ramya, if you want to just.
Yeah. So this child has this mutation, which is I spoke to the geneticist as well. This was reported as VUS, but I asked her whether the variant is significant. She told that in-house in Indian, their in-house data, this variant was found in 6 more. So she told the variant is strong. So I have taken it as a positive. Autosomal recessive, it is there. My main doubt is here, we have started CNS HLH like treatment only with IVIG, 1 gram per kg we have given, and dexamethasone, and then cyclosporin, and intrathecal methotrexate 1 dose we have given. This methotrexate was given 48 hours prior to this seizure episode. Whether this second scan changes represent that intrathecal methotrexate toxicity or something, that was one doubt. And the child has deteriorated. Today, the child has multiple seizures since morning, and with a good amount of epileptic activity in EEG as well. Currently requiring 3 anti-epileptics, and now with the low dose midazolam, he's being maintained. At this point, should we IVIG, cyclosporin, dexamethasone is going on. I have changed dexamethasone to pulse dose methyl pred. And do we need to add any further immunomodulation? Any reason for worsening or any other experience? If anybody else has, please let me know.
Yeah, the case is open. Yeah, thanks.
Yeah. And so just to one more this one. This time also we have done CSF just not to miss on anything, and to get a confirmation of CNS HLH. In cytospin also we couldn't get anything. Only 4 cells are there, and then sugar and protein is mildly elevated. Sugar is on the lower side, 47. Protein is 72, and gene expert is we have stopped ATT.
Okay, there's a comment from Sridhar requires bone marrow transplant.
Yeah, etoposide.
Yeah, etoposide. Yeah.
Yeah, bone marrow transplant, yes, but that we have given an option. But even the case report says that first we have to treat CNS HLH, and then after little stabilization, go for that. That is one thing. And etoposide or hematonc, Dr. Srikanth, he told it will be more for the periphery, not mainly for the CNS. That's why we have not gone for etoposide. Hello.
Yeah, Ramya. Yeah, I'll open the case. If anyone has, any comments. Yeah.
Nihaal, I think one of the questions is about toxicity on this particular scan that you're showing, right?
No, it's a follow-up scan, Dr. Mankat. That had a little some areas of diffusion changes, but more subcortical and more patchy.
But
more
even
or
on
less
this,
the same.
The imaging findings are same, but only diffusion changes slightly additional changes.
Yeah. Because we have to consider that in this particular case on the second time point, if you see the corpus callosum, etc., the entire white matter has this diffuse kind of signal abnormality, which is what, if you take the context of HLH out, you would consider toxicity as well.
No, I mean, just to add, this scan did not have any diffusion changes. There's a follow-up scan done on 15.
Yeah, by this time we didn't start treatment also. We have not given
the cerebral changes are known.
Yeah. The corpus callosum, I mean, it was there in the previous study too. I mean, not as prominent, but you can see over here,
Yeah.
the white matter involvement was there.
Yeah.
Let me see comments for. Okay, diffusion changes, worsening of neuroinflammation, bone marrow. Nothing would help, unfortunately. Intrathecal methotrexate helped, that gets a bit unevent themselves.
What is the scope for bone marrow transplant in your center at this point, though? I mean, we have had 1 or 2 cases gone through bone marrow transplant. The outcomes were, they kind of stabilized. Of course, they don't completely get better, but they do become quite improved clinically as well. But is it easy to get it?
No, Dr. Mankan. Currently, my setup will not, I mean, for bone transplant. I am just thinking to stabilize the child and then refer to them. Please let me know if any other inputs are there. Thank you.
If you want, I can get an opinion from here in terms of the national HLH meeting, and you can even present your case. I can connect you with the right people. It is being dealt with by on one side the inflammation team, and the other side it's also been reviewed by hematology, oncology, and that side. So the national meeting happens to them. But in terms of further suggestions, you did say you're following the recommendations. I don't know how clear the recommendations at the moment are for isolated CNS HLH in terms of management.
True. 2004 protocol is what we are following, but as you said, it is not an isolated CNS kinds. Yeah. Thank you. It would be great if you get me connected with you.
Yeah.
Yeah, sure.
Thank you. Nihaal, please let me know how to connect with the dots, okay?
Maybe you can wait for the end of the meeting. I have at least 4 or 5 more suspected HLHs.
Really? Okay.
Okay.
All right. Okay.
All right. The question from Jan, will Plex help?
No, it is not. I think it was mentioned in 1 or 2 cases, but no.
Yeah. Okay. Yeah. Sridhar also agrees. Plex. All right. We'll send the case over to Dr. Mankad and hopefully get an answer from there.
Yeah.
Yeah.
Thank you.
Thanks, Kamala.
Yeah.
Dr. Vivek?
Yeah, so moving on to something much simpler, this case is discussed here more because the neurosurgery colleague's grandson is, and he requested me to discuss it. So that was more of a reason. So 18-month-old boy who had a large head since his early infancy, and which was thought to be a family large head, as his father has got macrocephaly as well. But as it had gone above 97 centile, MRI was done. And then the radiologist has reported in the right quadrant there is a vesicular stage NCC. There is no history of seizures, just an incidentally picked up finding. So I was myself not sure if this really is an NCC. That's the only reason this MRI was put up. So he wanted me to just confirm with the people.
Okay. I have a non-contrast scan. On top, you have the flare sequence, and the lesion is in the caudate. The right caudate, you can appreciate this hyperintense lesion with a speck of hypointensity and some edematous changes around the lesion. On the flare sequence, again, similar changes, hypointense changes with a slight dot of a flare hyperintense abnormality out there. This is a virtual open space. It's not part of the lesion along the anterior commissure. Diffusion, no abnormalities. SWI, no blooming. This is a coronal sequence of the T2 on T2, and you can appreciate again a T2 hyperintense lesion with a T2 linear hypointensity within the lesion. This is just generalized appearance of the brain. You have some degree of reduction in the brain volume, some lateral ventriculomegaly. Yeah, this is all the sequences I have. I think contrast wasn't done, no, Dr.
No, contrast was not done.
All right. So the differentials, I think the chat is active. There, one with atypical VR spaces versus NCC. VR spaces, would it have a spec inside? I'm not sure. Would it can have adjacent inheritance changes. Yeah, I'll open the case for further comments. No other abnormalities in the brain except the volume loss and the ventricular.
At a very atypical place for NCC, caudate nucleus.
Yeah, it's an atypical place. Yes.
So atypical place, no history, 18-month-old baby, good socioeconomic status, you know.
But would the caudate cause it wouldn't cause seizures, no, Dr. Vivek?
No, he doesn't have seizures. He doesn't have anything. He just got the large head.
That might explain the lack of seizures, wouldn't it? I mean, caudate is not the primary center for a seizure. Yeah.
Somebody mentioned cryptococcus, but
No changes on SWI, Ali.
If this thing was not there, then you would say the large head is probably familial, Dr. Nihaal? Or you feel that there is a degree of atrophy there, which is suggesting something else?
Clinically, Dr. Vivek, large head? Sorry,
yeah, child is developmentally normal, large head, yeah.
Yeah.
This extracerebral space is normal for that age.
Yeah.
It has to be differentiated from atrophy. This is not atrophy. This is normal.
Is the ventricle more prominent than normal?
But in megalencephalic children, you often have some degree of enlargement. And if you follow up without doing anything, it's going to normalize.
Right. So it's just asymptomatic, and he wanted me to should I give 21 days of albendazole and steroids and everything if this is NCC? So do we think this is NCC? It could be.
I think the general consensus is that you can just sit on it and wait and watch at the moment.
So
it's
NCC,
a typical location for anything, including the caudate lesion, whatever it is. It's atypical for location-wise as a perivascular space as well. But I think the consensus seems to be more of a wait and watch and do nothing at this point.
So, any answer? What in the fifth image? Is there a scolex? Top fifth image, the last one. Yeah, scolex.
I mean, at least looks like it.
I think it's a traversing vein. I think a CIS3D would be okay, and also contrast may be needed.
Yeah, I agree with that. Yeah.
So, Bijay, what do you think it would be otherwise? Is it just a
I have seen some perivascular spaces with a perilesional hyperintensity, especially the temporal lobe. It is mostly described in the temporal lobe, but I've seen in the perivenular space in the trigone of the lateral ventricle, and that patient was symptomatic, and we thought it's a perivenular demyelination. So this child is asymptomatic. I think we should do just a CIS3D and contrast to make sure that it's a vein, and then follow up.
Right. And is there edema, or what is the hyperintensity around the space?
I'm not really sure, but in the temporal lobe, around typical VR spaces are described with the perilesional edema.
Okay.
This is
not other places.
The changes in the superior temporal gyrus look different and are probably not there at this age. This is a different appearance.
I think, Dr. Vivek, a complete study would be required. At least
contrast MRI and CIS.
And you can do a PASTA CIS over there.
And what did you say, CIS? Because that one I was not clear. Peri?
No, CIS. CIS is just CIS image, heavily weighted T2 image.
Yeah.
So we will see whether it's a scolex or it's a linear structure, because right now the T2 doesn't have the spatial resolution to resolve it.
Okay.
But is there a problem giving albendazole while you're waiting for all that, if there is still a concern about NCC? It doesn't have any side effects, right?
And it will die by itself also. Its child is asymptomatic. If it is, then it is a Yeah.
I'm just
So
thinking,
there is
you
no
know, in India,
answer.
albendazole is given, yeah, albendazole
Yeah.
is given left, right, and
And
center
he's
anyway.
going to
Now
give
you
it.
have
He's
a
going
question.
to ring me today, and he said, "I'm going to give it. It is NCC." He just came to me to. Yeah, he's going to give it. I know.
I think we should all have albendazole once in a while, right?
It's just simple but interesting. Like sometimes.
Yeah. Okay. Albendazole with steroids or just albendazole? Question from Anas. Dr. Vivek?
I'll just give albendazole, not steroid.
Okay. Okay. All right.
If 7 days is enough.
Okay.
Or even just a single dose placebo to satisfy the family.
Got it. Got it.
Might treat the perivascular space as well.
All right. Okay. We will move on to our next case. Dr. Vivek, if you have a follow-up study, just let us know. I think it's unlikely, maybe.
Sure.
It's giving albendazole anyway.
Yeah. Sure.
Sakshi, if you're there, or Dr. Rashmi?
Yes, sir. Yes, sir.
Yeah, go ahead.
This is a case of 7-year-old male child who presented with fever for 6 days, basically fever for 4 days and afebrile for the last 48 hours. And along with that, he had a history of difficulty in speaking and walking for the last 2 days, and blurry vision, and also in intermittently diplopia for the last 2 days. And on examination, the child was having horizontal nystagmus, and the child had a ataxic gait, and there was a past pointing present, and the reflexes were all brisk, and and also 2 days back, the father gave a history of vomiting. The child had 3 episodes of vomiting 2 days back, and there's no history of any travel or any like recent rash or any infection. Past history was not significant, and birth history was also not significant. And development wise, the child was normal, appropriate for his age. And on examination, the child was a little bratty. The heart rate was 62. The blood pressure was 108/60, and all other vitals were maintained. And on neurological examination, the child was alert, and the pupils were bilaterally reacting to equal and reacting to light. Horizontal nystagmus was present. The gait was ataxic, and Romberg sign was positive. Past pointing was present. The reflexes were brisk. The tone was normal, and the speech was slurry. And there were signs of the raised intracranial pressure. So we did the investigations, and CBC and CRP was.
We'll wait for the MRI first. Sakshi, if that's okay. Yeah. Okay. No encephalopathy.
Yeah, so we did a CT with contrast followed by CSF and then the MRI. Yeah.
Okay.
And we are
CT
from
was...
Bangalore, Rainbow Hospital, Bangalore.
Sorry. Yeah. Okay. So I'm going with the MRI directly because CT was normal. At least. So MRI was done on the same day, if I am not mistaken.
MRI was done the next day. Yeah, the next day of admission. Yeah.
So FLAIR non-contrast sequences, you can appreciate there are brainstem edematous changes. You can see over the midbrain, the medulla, the dorsal brainstem, and also the dentate is slightly hyperintense on the FLAIR sequences. Similar changes on the T280 sequences. Yeah, again, predominantly brainstem abnormalities. Then the spinal cord also was screened. Spinal cord, again, you can appreciate that the cervical cord has these long segment changes predominantly in the central regions. I don't have an axial section along it. Even the dorsal spinal cord and the lumbar is slightly hyperintense. Contrast was done on spine, so that there was no abnormalities, no cardiac or no root enhancement. Contrast of the brain, I can see that there is no significant enhancement. There's no dedicated optic nerve cut, but at least the one which I visualized, I could not appreciate any significant enhancement in the optic nerves. SAT sequence does not demonstrate any enhancement of the brainstem structures. Thinking of Raman encephalitis or Raman encephalomyelitis as one of the differentials for the imaging appearance, I think demyelination was kept as a second differential. So with that, Sakshi, you have any labs to corroborate?
Labs, yes, we send the CSF analysis, and the CSF analysis, it showed this thing, cell count of 15 and all lymphocytes. The glucose was 49, the corresponding GRBS was 100, and protein was 38. Gram stain showed no pus cells and no organism. And CSF culture was showed no growth after 48 hours. We sent the meningoencephalitis panel that showed HSV was detected low level, but then we had sent the autoimmune panel, CSF sample for autoimmune panel and paraneoplastic panel that came out to be negative. So based on the CSF reports and based on the MRI findings, we had already started the child on ceftriaxone, vancomycin, and acyclovir. So after the culture report, we stopped vancomycin and ceftriaxone, and we continued with acyclovir, and also we started him on low dose methylprednisolone, 10 mg per kg. And the child showed a lot of clinical improvement. The gait improved, the nystagmus was getting better, and the reflexes got back to normal. The pass pointing that we were getting initially, that also improved. So overall, the child was improving clinically, like in 3 days, and then we discharged him on oral steroids and acyclovir for 21 days.
Okay, Dr. Rashmi, any comments?
Yeah, so initially when he presented clinically, he looked very much like acute cerebellar ataxia because all cerebellar signs were there. Because the CT was normal, we went ahead and did the CSF, and then the MRI stumped us because it had all these midbrain changes and brainstem changes and all that. And there was HSV was positive in the CSF. But because these are such atypical changes and HSV is known to cause immune-mediated stuff, we decided to give steroids, but we discussed a lot and planned to give a slightly low-dose steroids rather than the 30 mg per kg. And he's made good improvement. So now he's on 2 mg per kg of steroids, and we are going to give the acyclovir for 3 weeks. And on reading about this, I think brainstem encephalitis can occur in HSV, but it's a very rare. Usually HSV affects the temporal lobes, and that's how they usually present. And I think one which Dr. Sakshi has mentioned is the EEG.
No.
EEG had an abnormal, did not have posterior dominant rhythm in the awake state, suggesting mild encephalopathy, but sleep, spindles, vertex, everything was there, and there were no focal epileptiform abnormalities on the EEG. Because the parents had concerns that one of the other symptoms they gave was suddenly he was waking up and he was having these jerks. So that's why we did the EEG. But that just got better by itself. We didn't give him any anti-seizure medications.
Okay, yeah, all right. Case is open.
Has anyone else seen a similar presentation?
So is this para-infectious HSV-related changes, or you're treating it as primary HSV-related changes?
We are doing both because
Okay.
it was very short period, no? There was fever,
Yeah, 6 days.
said 4 days of fever and 2 days afebrile. It's not like he had fever 2 weeks back and now he's presenting. So we thought we will treat both, and we can't ignore a positive HSV in the CSF. I think it'll be very tough to ignore that.
So just to point out, diffusion and GRE did not demonstrate any abnormality.
I was thinking maybe because the midbrain and pons are connected by the peduncles, and that's why he had so many cerebellar signs rather than any brainstem signs, or I don't know. So that's what I was thinking.
Dentate is also slightly bright for the age. So there are some edematous changes out there.
Oh, the edematous changes in the dentate nucleus as well of the cerebellum?
Yeah.
Okay, fine. We didn't get a report with that. Can you just show us that?
This panel out here.
Okay, then.
And over here.
Uh,
Any history of dog bite? Question from Dr. Nihaal.
Yeah, we specifically asked. There is no history of dog bite. In fact, we thought that if he gets worse, then we'll go ahead and do rabies antigen. But because he got better, we did not do that. We specifically asked him for that, and we kept it in mind. And we said, if he gets worse, we'll do the rabies antigen. Yeah, Dr. Sheila said there's altered sensorium, but there was no altered sensorium clinically as such, but the EEG was mild abnormality was there. We did not have posterior dominant rhythm in awake state.
Nihaal, can you confirm what's happening to the cerebellum? Is it an overall or just limited to certain parts? The swelling from what you see?
Yeah, so what I can see is brainstem definitely, dentate definitely, but the cerebellar cortex, I could not appreciate any changes.
Okay.
Can one repeat a CSF in 7 days, and if PCR negative, stop it? Like, is that because you're giving 3 weeks? Is that
Yeah, yeah. I mean, I was not that brave actually. I mean, I can discuss. I mean, so far it's gone for a week now, so it's 2 weeks to go. You feel that if the PCR is negative, then it's worth a try. Is it? I was thinking that there is a lot of reports about relapse, no, of inadequately treated herpes.
But ideally, they say you should give 14 days and do a PCR. If it is negative, you can stop it on 14th day. Otherwise, give it for 3 weeks.
Okay. Another option I thought, if the cannulas get very difficult, is to give 14 days and complete the course with valaciclovir. That's what I was thinking. Anyway, I'll discuss it with the parents, what they feel about if we get to that point.
This PCR, can it differentiate between subtypes of HSV, or is it always looking at all HSV type 2?
We assume that it is.
We had seen a case, young child with herpes simplex type 6 with brainstem involvement, just like adenovirus.
Okay.
Okay.
So that's
Jayan
a very
says we can
relevant
differentiate.
point because just in last few weeks, we had 2 children who had febrile seizure. They were very irritable. And we did CSF and MRI was normal. And CSF had evidence of aseptic meningitis, and HSV1 came positive in both of them. So we were also thinking whether HHV6 is causing it and the PCR is picking that up. So both of them had aseptic meningitis, just few cells, 30 cells, protein normal, sugar, protein slightly high, sugar normal, 2 patients. They were very irritable after the febrile seizure, 1-year-old, 1.5-year-old, no MRI changes. And HSV PCR came positive, HSV1 in both of them. So because HHV6 causes febrile seizure more often, so that was so that's something worth asking people where I don't know the answer, whether HSV and HHV6 because of the, and can you do a IgM in the blood HSV? Because IgM blood HSV is easy to get. If it is negative, then this is a false positive.
Yeah, we can do an IgM in the blood, and I can also discuss with the microbiologist whether he can differentiate between the subtypes of the HSV, because HSV6
if IgM is not there, that means the child hasn't had that infection because IgM HSV should be positive now.
Okay. Yeah, we can do. The thing is, we send a lot of HSV PCR. We do a lot of CSF and send a lot of HSV PCR. Most of them come negative. So it was hard to ignore. In fact, I spoke to the microbiologist and he said, no, this is not false positive. This is positive. I was thinking maybe this child had, had partial immunity, had tried to fight the infection himself. And then there was this immune mediated. That's how I looked at it. But because HSV encephalitis can cause a lot of immune-mediated things, we did the full.
You are right in treating. Anybody would treat. So, but when you have time now, while you are treating, whether one can.
We can look into it a bit more deeper now. Yeah, do that. We'll do a HSV IgM. We'll discuss with our microbiologist whether we can do the subtypes of the HSV. And we'll go ahead and
subtypes of the DNA viruses. So,
okay, subtypes of the DNA virus, and then we can see see how we get along with the treatment. So far, 1 week is done. So 2 weeks.
Because the BioFire panel is there in which HHV6 and HSV are separate. So, if you
Oh, okay. Ours is not BioFire, it's from Micro Labs.
okay.
Yeah.
Okay, Dr. Rashmi, get back to us if you have any further labs.
Okay, thank you so much, Dr.
Yeah,
Nihaal. Thanks.
right, thank you.
Thank you. Okay, bye.
All right, from Bangalore to now Hyderabad, Anas.
So, 12-month female child born to 4th-degree consanguineous parents. Two concerns: the parents, development delay, motor more than cognitive. Baby had attained only partial neck holding, no rollover, not reaching for objects, no pincer grasp, only cooing, social smile, and good eye contact. Response to name calling was present. A history of occasional choking while taking feeds. And this past history of generalized tonic seizure at 3.5 months of age, but it's well controlled on antiepileptics. So they came to us primarily for development delay. Baby was a failure to thrive child, 5.3 kgs, height 61 centimeters, height circumference 40 centimeters, or less than third centiles. Sparse hair, short, stubby nose, dry skin, firm hepatomegaly. AF was open. Cortical fisting was there, curling of toes, truncal hypotonia. Lower limb spasticity was there, right more than left, and brisk reflexes. So more of pyramidal and extrapyramidal and failure to thrive. Got an MRI as part of evaluation.
Okay, I have only film images, so slightly pixelated. Diffusion on top and ADC on the bottom, and you can see that there are symmetrical changes in the confluent changes in the bilateral frontal lobes involving the cortex and white matter. The basal ganglia demonstrates these edematous changes. You have the central thalamic nuclei also demonstrating cytotoxic edematous changes going down into the cerebral peduncles and the periaqueductal gray matter. Middle cerebral peduncles also have changes along with the pons. T2 and play, I think I have a T2. Yeah, T2 again, you can appreciate the edematous changes, subcortical cortical regions, predominantly in the frontal lobes. Again, basal ganglia, thalamic abnormalities, and brainstem abnormalities. Typical examples as what we think the imaging phenotypes: primary responsive, mitochondrial, organic aciduria, based on the imaging. I mean, at least on the initial imaging of the scan. Then I think Anas, we have additional data.
The main was height and weight and organomegaly. So child was simultaneously being worked up for that as well. TMS and GCMS was normal. GCMS had some mild abnormalities, but not significant. Child was reviewed also with the endocrinologist and workup was done. Triglycerides were elevated because of the organomegaly, short stature, there's no hypoglycemia, but as part of the failure to thrive workup, it was done for a glycogen storage disorders. But thing is, and we got genetics then, and genetics showed PHKB. It's a glycogen storage disorder type 9B. All the features were matching with the clinical phenotype, other than the radiological features. So that was the main. But on reviewing literature, I mean, although the MRI findings are not typically reported with this gene, hypoglycemia can they have reported that hypoglycemia as such can cause such similar changes in the basal ganglia. So just wanted to review if anyone has any experience with the same.
Okay, I could not find any imaging which matches our phenotype. There were changes of atrophic changes and white matter changes, and the typical hypoglycemic changes in the cortex. So I don't have any imaging literature for reference. So if anyone has similar experience and if this is truly a pathogenic variant, open for discussion.
Otherwise, the clinical phenotype is a match other than the radiological features.
Okay. Nope. Anas, I don't think people have seen similar cases. At least in literature, I could not find any matching cases. Would it fit into fatty acid oxidation, or is it a completely different spectrum?
Ketone bodies
Hypoglycemic
were
changes.
ketone bodies were positive in the urine, and so unlikely.
And
TMS also was normal.
Biotin thymine was checked.
Thymine levels were not done. No, thymine we have not done.
Okay.
Parental screening, we have advised them. We're waiting for reports.
But parent screening will not help very much because this is a homozygous variant. Both parents will be asymptomatic carriers. But this MR is kind of independent. It's either a second disease or a complication. I'm not sure whether hypoglycemia makes this pattern at this age. Does it?
I agree with you, Aidan. I don't mean typically it does not cause such changes.
It looks more mitochondrial, right? This.
Yes.
So could be a second hit. Should we looking? Are we looking at another coexisting? Should we work up for that?
I think the answer to that is yes, isn't it? Mitochondrials is what we should be looking at, and whether this is being unmasked by another metabolic problem that you've described and found would be the question. But the areas that you have involved here are all energy dependent areas, which is what respiratory chains would do.
CSF lactates, Anas from Dr. Namrata. Yeah, I think any other the IEM such as mitochondria to be evaluated because it doesn't look typical for the described hypoglycemic changes.
Thank you. We'll review. Thanks so much.
Yeah. Okay. Anas or Harika, if you're there.
Yes, sir. This is 36-weeker preterm male child, now corrected age of 40 weeks, twin to born out of LSCS non-consanguineous marriage, brought with the complaints of LRTI, was on HFNC for 2 days. In view of worsening sensorium and respiratory distress, child was intubated and kept on mechanical ventilation for 4 days. Child was given a trial of extubation on 4th day, but there was a failed extubation and also decreased movements were noted. In view of that, MRI brain was done and also metabolic testing was done. In view of persistence of these abnormalities, NCS was also performed and IVIG was given and referred to RCH. And here on examination, baby was on mechanical ventilation, alert, fixing and tracking in horizontal plane, bilateral pupils at 2 mm reacting to light, no facial weakness, no pooling of secretions, no tone circulations, and generalized hypotonia and intercostal weakness is noted. Left limb showing positive movements with areflexia. Right limb has good anti-gravity movements and brisk knee jerk is noted. And we repeated MRI brain with spine.
Okay. Again, very pixelated images. I have only one film out here. The main changes which were described were the changes in the brainstem. Again, you can appreciate. I hope you can appreciate the cerebral peduncle abnormalities on the diffusion weighted scans. The rest of the findings of the brainstem and cerebellum, I'm not able to clearly evaluate. Not sure if it's cerebral edema or in the supratemporal brain, but at least these things stand out in the brainstem. Follow-up scan, I think done 3 weeks later. Diffusion changes I have not seen on the present scan. On the T2s, possibly the midbrain is slightly hyperintense. The pons is also slightly hyperintense. Medulla also has some T2 hyperintensities. Supratentorially, for the age, I think there were no focal lesions, no structural abnormalities. The spine was done on the axis. The changes that we appreciate on the axis sequences, there were some abnormalities, especially in the central areas of the cervical cord and also extending up to the lower dorsal cord. So based on that, I think, these were the follow-up labs. Harika, if you can just complete.
Yes, sir. CPK is the normal, 48 micro per liter, and newborn screening was normal. Serum lactate is normal. Serum pyruvate is also normal. And TMS, GCMS were done normal. CSF, PCR for viral panel, it's normal. And the serum glycine was 456, but serum CSF to serum glycine ratio was normal, and CSF lactate to pyruvate ratio is also normal. And we have done COVID and flu panel and adenovirus, it was negative. And ET culture was asked of Pseudomonas aereus nigra. And in view of this clinical and radiological presentation, we labeled it as rhombencephalomyelitis.
With acute flaccid myelitis. Okay.
With acute flaccid myelitis.
What was the query? Is this the causative thing or any other alternate pathology abnormalities?
And based on the initial neuroimaging, the diagnostic workup was done in hyperglycemia because of the changes reported by the radiologist. But when the hyperglycemia. So based on these, the child was referred to us, and then we saw this asymmetry of lower limb. So we thought maybe rhombencephalomyelitis can explain everything, but we have drawn blank on all the investigation. Just for counseling, I mean, clinically and radiologically, we're convinced it's just rhombencephalomyelitis, but just wanted to know what's the experience of people with other centers, and could it be missing something in terms of workup? Maybe it's improving otherwise of mechanical ventilation now on HFNC.
Okay, case is open.
Brisk on the right side, absent on left side. DTRs.
And CSF was normal, did you say? Cells.
Yes, sir. CSF was normal.
Normal cells, right?
Yeah.
And is the anterior horn involved in the spinal cord? Okay.
Yeah.
Yeah.
The lower segments, yeah.
So that will favor it. And you should, I've now started in all these cases to do an immunoglobulin profile for common variable immunodeficiency. Because enteroviruses, especially in CVID, are more common. And few of the cases of CVID have been picked up because of this. So just a suggestion. Because he's so young to get this. But the only thing is at 4 months, you don't get CVID often. It starts at 8 to 12 months. So maybe if he was a 1-2-year-old boy, I would have done immunoglobulin profile before giving IVIG. Because we are missing too often immunodeficiency states with CNS involvement. So at this stage, yeah, but later on. So if he was a 1-2-year-old who comes with a rhombencephalomyelitis enteroviral infection, we should do an immunoglobulin profile.
Okay, let's see. Maternal immunoglobulin is confirmed IG profile from Sridhar. NCS, okay, not done. Was done at referral center, okay, sorry. But Rashmi says okay, that is for the previous case. HST1 positive, all right. Immunoglobulin profile not recommended before 6 months of age. Dr. Vivek from Jayan. I think you have
Yeah, so
that.
if a 1-2-year-old, but at this age, if one is worried, one should do flow cytometry.
Okay. So we're going with inflammatory changes. I mean, okay, AF infective or inflammatory rhombencephalomyelitis, acute flaccid myelitis with no alternate.
Is that right? Anterior horn will be involved?
Yeah, it will be involved in AFM,
yeah.
Okay. Yeah, Dr. Rashmi, if you just want to update.
I just had another look at the report, and it is saying it is definitely HSV1. And the lab has developed their own test, which is a 90% sensitivity and specificity for 88 copies per microliter of HSV1.
Okay. So HSV1, going with HSV1 as a diagnosis. Or you just still do the IgM?
We'll go ahead and do the IgM.
Yeah. Okay, all right. Okay. All right. So next case, Dr. Sarbani is there?
Yeah, hi, Nihaal.
Yeah.
So this is a 8-month-old girl. She presented with respiratory distress and she had to be immediately ventilated with the X-ray showing a right upper lobe pneumonia. The interesting part was that this is not her first episode of pneumonia. So when we reviewed the history, we found out that she has been admitted 4 times in the past for pneumonia. And she's 8-month-old. Apart from that, she had microcephaly, developmental delay. Her developmental age is around even less than 4 months. Just head holding, some vocalization. She had significant hypotonia. Her knee jerks were preserved. No hepatosplenomegaly. So when she came, she was distress was significant enough for ventilation. And at that time, she had acidosis, which corrected on improving her hypoxia. She had no hypoglycemia. She's born of a she's born of a consanguineous marriage, and this is the first child. And there is a brief NICU stay on day 6. On day 6, she had weight loss and was not feeding well, and that was the admission. Present blood work shows anemia, HbF7, WBC is high, suggestive of infection, and platelets are low. Now, the thing is, so let's take a look at the MRI and take it from there.
All right. MRI, you can see that the head is small. You can sutural ridging is there in the coronal sutures out there. Some degree of atrophy, hypertense changes in the white matter, periventricular and deep white matter. Also in the partially in the globus pallidus and the thalami out there. Brainstem, again, there is some abnormality in the pons, some abnormality in the cerebral hemisphere, especially on the right side. Diffusion changes, you can appreciate these symmetrical abnormalities in the bilateral globus pallidi and also along the brainstem tract. So those are the additional findings on the diffusion sequences. Okay. So no abnormalities on the GRE sequences. What was the age? Sorry, Sarbani?
8 months.
8 months. Okay. So corpus callosum is definitely atrophied. Brainstem also there's some degree of atrophy or hypoplasia. So going by the symmetrical changes in the globus pallidus, I think suspicion was cobalamin related disorders. Cobalamin pathway related disorders. Yeah.
So is the MRI typical of anything? I personally think that clinically, considering the microcephaly, the delay, the consanguinity, the hypotonia, and the severe suck swallow issue, which is leading to pneumonias, this is probably a cobalamin metabolism disorder. But is the MRI helpful, or it's non-specific, or nothing? Or should we just wait for the WES and see? Of course, I've started the treatment.
I would say yes, but I'll open the case. People have suggestions. I think Sridhar has mentioned in chat, I think MTHFR related genes, hypermodularinemia. Yeah, PDH, I agree. Thin corpus callosum, I think goes with the generalized reduction in the volume. Yeah, PDH, a mitochondrial can be a differential. Beta ketothiolase, we have seen with bilateral changes in the globus pallidus.
So when we say Lee-like syndrome, this doesn't look like a Lee-like syndrome. So I won't think mitochondrial. And particularly responded quickly.
Yeah. No, only in the imaging part, the pyruvate dehydrogenase complex usually have more globus pallidus involvement.
Right.
I'm not calling it Lee-like syndrome, but only the involvement of the area as can add that to the differential.
Right. So CBLC is my bad. Like MTHFR, doesn't present in in such a terrible state. You know, the neurological findings in this patient almost on the verge of life-threatening pneumonias repeatedly. In this time, almost were about to discontinue treatment. The parents were about to decide to discontinue treatment because this was their fourth admission for pneumonia. So I think cobalamin C is my bet.
Yeah.
But yeah. All right, so I've started it. Yes.
Sorry.
So MTHFR, as you said, in the first year presents with hypomyelination. So
Right.
and later on so yeah, this is more like intracellular cobalamin, CBIC, and is the uric-creatinine normal? Renal function normal?
Normal.
Right, because that is important to consider together. So MTHFR presents more with hypomyelination in the first year. At least the two cases I have, they had hypomyelination. We did homocysteine, it was high, and then we did MTHFR, was positive. So yes.
Yeah, as far as I remember, hypomyelination with cerebellar atrophy is one of the imaging phenotypes for MTHFR.
Right. And because this becomes one of the treatable disorder. So if it's a treatable disorder and this kind of presentation, so if the MRI gives us some clue, because I just sent the homocysteine based on the clinical and the anemia, the two cell line depression. But the MRI, if it gives us any pointers that this is intracellular cobalamin metabolism, because it's a treatable disorder, it makes a huge difference.
So the globus pallidus involvement is in favor. So if you have a globus pallidus involvement like this, with the thrombocytopenia, and so B12 intracellular, non-functional, because exactly same situation 6 months back we had the MRI, we didn't have the homocysteine, we hadn't sent that day, and I think later we were going to withdraw the child was so bad.
Exactly.
And family said that will continue for 3 more days, and next day penny dropped, and I think I sent homocysteine, it came high, and then I had to revert back with my counseling. Initially her counseling that this is mitochondrial, there is no hope, and then the hope changes, we had to backtrack. So happened with me just 6 months back, same MRI. It was intracellular cobalamin defect.
Great. No, so it helps if I have other people with a similar experience. It reassures me, yes, because I'm continuing treatment and I'm hopeful for the baby, yes.
Question of GCMS, TMS, was it done?
Yeah, so we've sent the whole exams.
Okay, directly for the whole exam. Okay.
Yeah, directly for the whole exam.
All right.
And so because just for us all. Sorry, yes, Sabini,
yes.
go on. You finish first, Sabini.
No, I mean, I did not send the TMS. So went for the whole exam and started the treatment, yes.
It's just with this imaging, for me, the learning was that always do homocysteine, which I was not thinking before that easily. So homocysteine is a very important test for us. We should do it more than we do sometimes. But for this situation, yes.
Treatment in the form of hydroxycobalamin, Sarbani, Sridhar asks.
Hydroxycobalamin, pyridoxine, folic acid, and TMG, all.
Okay.
The betaine.
All right, we'll wait for the sequences, and I think
yes,
consensus is that it can be a possibility.
Yes.
Okay, on to our next case.
Yeah, so this one is a 7-year-old boy. He was admitted for PU. So his fever didn't respond beyond 2 weeks. And the pediatrician and the intensivist were trying to find out the cause for the fever. He was thoroughly investigated, but they were not able to find anything useful to etiology. So there was this ascites, mild pleural effusion, mild pericardial collection, mild anemia, but nothing exactly why the PU for 3 weeks. And then on the 4th week, his sensorium started going down. and he threw a single seizure. So that was when the
First
MRI was
MRI was.
done.
Okay. All right. First MRI on top place sequences, multifocal abnormalities, partially controlled abnormalities in the subcortical cortical regions along the cingulate region out there, parietal lobe, the right frontal lobe. Along the anterior commissure, you have the bilateral hyperintense changes. The GNU has a small focus of hyperintensity out there. The right temporal and the occipital region also has these hyperintense abnormalities on the flare sequences. Brainstem abnormalities, multifocal lesions, bilateral median temporal lobes also has hyperintense abnormalities. Coming down to the cerebellum, you can appreciate the focal abnormalities in the vermis, also along the cerebellar white matter out there on the right side. In the inferior cerebral hemisphere, the medulla also is slightly edematous out there. Going down to the lower aspect of the medulla along the thoracomastoid junction. I'll have a contrast. We'll look at the other convention sequences the next slide. Contrast, yeah, from some degree of enhancement, nodular enhancement in the lesions along the right frontal lobe, some ring-like enhancement along the incingulate region out there. Optic nerves, I could appreciate especially the left optic nerve appeared to demonstrate some degree of enhancement. The other lesions do not demonstrate significant enhancement. And then the SWA sequences, I could possibly identify some punctate areas of blooming on the cortical subcortical regions out there, especially you see along the midline, the paraphysetal region. Here you can see the right periinsular or the insular cortex. You can appreciate these tiny areas of blooming along the temporal lobes, the occipital lobes, and the bilateral cerebellar hemispheres. The only abnormality which demonstrated any diffusion changes was this focal abnormality on the left parasagittal region in the frontal or the parietal region. Spine was done. I don't have axials. Cannot appreciate anything. Maybe I don't know if this is real or not. But nothing significant stands out on these spine sequences. If Yogesh is there, he has seen the scan. Maybe he can help us out if we found anything on the spine. This was last minute. I just put this as last minute. So coming on to the second. I think this is the second MRI. Dr. Sarvani, if you want to just tell us about the interval time period clinically and treatment wise. All right, spine is normal from Yogesh. Great. Okay, that's the first MRI. Dr. Sarvani, before the second MRI, any additional clinical details, progression? Dr. Sarvani, are you there? Am I audible?
Yeah, hi. So
Yeah,
serum anti-MOG antibodies were negative. CSF was normal. He received methylprednisolone and IVIG and deteriorated. Developed further deterioration of sensorium and right hemiparesis. So GCS went to 8. That was from first MRI to second MRI almost in 6 days' time. This is what happened.
All right, second MRI, as you can see, appreciate extensive lesions out there, progression in the bilateral hemispheres, the deep brain nuclei also now more extensively involved, brainstem more extensively involved. Cerebellum also you can appreciate there's a progression in the edematous changes. Some degree of hypointensity is possibly suggestive of some necrotic abnormalities in the brainstem out there and the cerebellum. Diffusion, I had this additional focus of diffusion change on the right anterior cingulate region, the left right peripheral region, some diffusion changes in the midbrain out there. And now you can see that the focal punctate lesions on the SWA sequences on the previous scan now have significant progression. These microhemorrhagic foci, predominantly subcortical cortical regions in the hemispheres, also involving the brainstem, cerebellum. And then I think we have, contrast. Just a focal enhancement out there in the right anticingulate region. But other than that, I cannot appreciate any other areas of significant contrast enhancement. Again, optic nerves appear slightly, especially the left optic nerve demonstrates some degree of uptake, possibly on both sides, but left more prominent. SAS sequence contrast study slightly degraded due to motion, but nothing stands out there in the pituitary or the stellar region. Then we have a third MRI. Before the third MRI, Dr. Sarvani, if you want to update.
Right. So we went to second line immunomodulation, rituximab, cyclosporine, etoposide. Now there is a significant past history in this child that 4 years back, he had an abdominal pain. After the abdominal pain, he stopped moving his left leg, the left leg monoparesis. And at that time, the MRI was suggestive of ADEM. That MRI we don't have. And at that time, he was treated with steroids. At that time also, serum anti-MOG negative antibodies were negative. So he has a past history of a clinically isolated syndrome. With the second line immunotherapy, he did very well. Improved in sensorium, has now almost come back to his pre-morbid state, except for the emotional lability and mild cognitive issues. So this is his MRI after second line immunomodulation.
All right. The most recent MRI, and you can see there is significant improvement, at least in the imaging aspect. The edematous changes have significantly reduced, only residual changes along the frontal lobes of their cingulate regions. The deep brain nuclear changes have almost completely resolved. Brainstem also is a significant reduction. Cerebellar involvement also, there was significant interval reduction. Diffusion, I could not appreciate any new changes on diffusion. So yeah. All right. Sorry, I think I put the. All right. So this is the, as Professor Bani has already mentioned, the first MRI was suggestive ADM, and then the question was, is this a seronegative MOGAD or is it a primary HLH related to a genetic abnormality?
Right,
MOGAD
but
with
the is negative.
MRH.
So his whole
Yeah.
exome sequencing is negative for LHLH.
All right. Yeah.
So now the question is about his second line immunomodulation. How long to give? Because should we consider this some kind of a seronegative MOGAD, or the genetic studies have to be reviewed from some other lab? It's negative for primary HLH.
I haven't seen MOG with hemorrhage, Professor Bani. That is one pointer. Yeah, Sridhar also agrees with me.
Right, right.
Would you consider vasculitis as a differential?
Right. So primary CNS. And
Vasculitis
one
with
episode 4 years back and one now. Two long interval between two episodes.
Okay, Dr. Vijay also says possibility of vasculitis. Viral PCR from Dr. Prerna.
Yeah, negative. CSF, negative, completely negative for everything. So routine, viral panel, cultures.
Ferritin, CBC.
Yeah, ferritin is high. And he had anemia even this time. And the bone marrow studies were done by the hemato-oncologist, which shows hemophagocytes. And in the past, when he had the history of ADEM or clinically isolated syndrome, it is mentioned that he has unexplained anemia at that time in his summary. And he was asked to follow up for the anemia. Yes, EBB was positive. EBB positive. So as far as the hemato-oncologist is concerned, this is EBV related HLH, and this patient must be having a genetic, must be having a primary genetic disorder, but then we may have to repeat this double whole exam again after a while or something, or ask for a review in the whole exome by somebody else.
So look for perforin mutation from Dr. Vivek, Dr. Namrata, and parental
Not for
testing.
the mutation, you can just do the biochemical perforin deficiency test, which will cover 60% patients, because gene might be missed in TRON or as far as I know, Sarvani, you can confirm with them, because there is this, is this right? There is a blood test, perforin deficiency, what is it, biochemical test? Yeah, there is a test before going to the genes. So that will at least pick up your perforin gene problem, 60% patients. So because sometimes genes, so it's like doing the biochemistry for HLH, like doing the TMS for HLH. So that comes very quickly, and it's not costly, 4,000.
And it is not affected by immunomodulation?
Sorry? No, it's not no, it's not, it shouldn't be affected. Yeah.
Okay.
So
sure.
You're not well.
No, it's okay. Some bronchospasm, yes.
Okay,
So
so
yeah,
we're going with
just for
6.
academic
Yeah.
discussion, there is no ring enhancement, but aspergillus can present like this. But in this case, obviously things have improved. Is
Yeah.
that a differential?
Let's see. I couldn't appreciate any focal lesions. I mean, yeah, they have hemorrhagic abnormalities, but yeah, as you say, the enhancement pattern is more confluent edematous changes rather. I mean, widespread edematous changes. Aspergillus, I would appreciate some focal abnormalities, especially on the contrast.
Right. Okay.
Okay, Dr. Sarbani, if you can get back to us with the whole exome and the performance studies.
Okay. WS reanalysis and performance study.
Yeah.
Thank you so much. Thank you.
Yeah, thank you. All right. Prashanti, are you there? Or Apurva, Dr. Lokesh?
Yeah, I'm there.
Yeah, okay.
So this is a 2.5-year-old girl, initially presented with 5 days of fever, followed by seizure and encephalopathy. And after the seizures and encephalopathy, she was shifted to us. She had LRTI features, fast breathing, bilateral crepitations, and rhonchi. So she was intubated in view of encephalopathy initially, but then she progressed to requiring HFO. Pressure requirements went on increasing, oxygen requirement went on increasing. So first scan was done before she went on to HFO, just before intubation.
Okay, let me just quickly show the scan.
Yeah.
All right, the first scan I've just put up diffusion because the primary changes are on the diffusion abnormalities. So you can appreciate subcortical cortical areas of diffusion changes almost involving the bilateral hemisphere, some sparing in the central regions. But yeah, these were the main changes on the first scan, subcortical cortical involvement, bilateral hemisphere.
So for these, we had done CSF analysis, which was normal. CSF PCR was done, which was negative. So thought of autoimmunity, AELRD kind of picture, and we had given, we could not give steroids. She was having high grade fever spikes, and she went on to HFO. So we initially gave IVIG, and over 2 days when her fever started subsided, we started giving pulse dose steroids. For etiology, we had also done COVID antibodies, and which were very high, more than 250. Also looked for scrub typhus IgM and other mycoplasma IgM, which were negative. So overall, we thought COVID related. She had mild transaminitis along with these findings. Other systems were normal. So lungs and mild transaminitis and neurological involvement. So we thought probably COVID related and started her on steroids and IVIG. During the HFO, when she had unequal pupils, suggesting brain edema was increasing. But because she was on HFO, we could not do any MRI. We just increased her anti-edema measures, mannitol and 3% NS. And slowly she recovered, and she was extubated from HFO. After extubation, she was significantly encephalopathic. But slowly it was improving. But one day there was some dip in sensorium that she was not opening her eyes, and spontaneous movements had decreased. So we repeated an MRI at that time.
All right. I think MRI was approximately 10 days later. Along with the peripheral regions, you have additional edematous changes now in the basal ganglia, also possibly in the pulvinar and centromedull thalamic nuclei. You can better appreciate and correlate that with the flare sequences. You have the deep gray nuclei now demonstrating additional edematous changes. There is a subdural collection out there along the left part cerebral convexity. Some brainstem edematous changes also, if you see on the phase sequence out here, and also in the midbrain cerebral peduncles. So there is progression in the edematous changes. So now there's more involvement of the central structures. Non-contrast T1, you can appreciate the thin subdural collection, hematoma along there. I think if you see there was some degree of thrombosis also. You can see the T1 hyperintensity along the transverse sinus and the sigmoid sinus. This had actually extended up to sigmoid sinus, transverse sinus, and the distal interjugular vein. SW sequences again corresponding abnormalities around the subdural areas, but no parenchymal hemorrhagic foci. Post contrast, this was already T1 hyperintense, so that's subdural bleed. So there's no other significant areas of enhancement, especially intracranially. Yeah, Prashanti, after that.
stage, we thought that the progression must have been during the unequal pupils, and that time it must have progressed for all the edema. And probably current dip in sensorium is because of the CSVT, sinus venous thrombosis. So we started her on enoxaparin, and gradually she was discharged. Her sensorium kept on improving, spontaneous eye opening, some vocalizations. She started having dystonias after some improvement, so upper limbs and lower limbs. So with physiotherapy and management, she is slowly improving. So follow-up scan was done after 6 weeks to stop enoxaparin to see if the sinus has opened up.
But no interval clinical changes, no?
Sorry?
Significant changes. No interval clinical abnormalities in
Clinically,
neurology
no.
wise.
Clinically, she's gradually improving. She has significant dystonia, which we thought is a sequelae of whatever has happened.
Yeah.
And she was improving. Her sensorium was improving. Parents say she started having some amount of sucking movements for lollipops, and
Okay.
they feel she is slightly responding to this thing. She becomes apprehensive when she comes into the hospital. So clinically, no deterioration, no fevers, nothing, no vomitings.
You know
It
why
was
I'm
just
asking the question.
sorry.
Yeah. You know why I'm asking the question, because the follow-up
Yeah,
MRI.
yeah. There is no clinical deterioration at
Yeah.
all. So it was just
Okay.
a regular follow-up scan to look for the resolution of venous thrombosis.
All right. The follow-up scan approximately 2 months later. You can see now extensive white matter changes, predominant white matter changes. You have the non-contrast based sequences out there. The mid and posterior cerebral hemispheres demonstrate these significant confluent abnormalities. Also in the frontal lobe, some rarefaction in the temporal abnormalities. The T2 weighted sequences better demonstrate the changes. Bilateral hemispheric abnormalities, white and gray matter involvement. Again, predominantly affecting the right temporal and occipital and parietal region. And some degree of volume loss in the supra and infratemporal brain. Non-contrast T1 weighted sequences are there. Some degree of cortical lamina necrosis or some circle hyperintensities along the bilateral hemispheres. SWS sequences, I've just zoomed in the abnormalities out here. Again, microhemorrhagic foci in the subcortical cortical regions on the bilateral hemispheres, more on the right side. Post-contrast leptomeningeal enhancement, nodular enhancement along the abnormalities over here you can appreciate on both sides. But yeah, this typical, this characteristic leptomeningeal enhancement with some nodular deposits also in the leptomeningeal spaces. On both sides, the right more than left. So MRE was done. Again, you can see residual areas of thrombosis, partial filling out there. Now in the post-contrast, the orbits, the optic nerve demonstrates some degree of enhancement. The question for the first scan was ALARD was one of the imaging phenotypes. Again, we have discussed this many times. What is ALARD? But we can go with diffuse exotoxic brain injury. Follow-up, thinking of possibility of a CNS vasculitis, post-infectious vasculitis, given that the progression and the abnormalities on the white matter changes and also the microangiopathy-related abnormalities. Another consideration was HLH. I'm not sure if the labs corroborate with it, but can present with these exotic brain injury initially and can have optic nerve involvement. A tube factor demyelination was kept as a differential, but the enhancement pattern was not very typical of a tube factor demyelination, given the leptomeningeal enhancement. So are we dealing with a fungal, at least an infective abnormality, secondary causing vasculitis related changes, or is there any other possibility for this case? So I'll open the case where anyone has further suggestions. Yeah, Prashant, sorry.
She had been on steroids, so secondary fungal was one of the top things we were considering. We did a repeat CSF analysis, which is showing only slightly raised proteins, 80, but cells are normal, sugars are normal. Fungal cultures were sent, that is negative. PCR is negative. And MOG and NMO we have sent, that is also negative. Serum galactomannan we did, mainly we were considering fungal, so they were all negative. So right now we have planned for a biopsy because we are not sure what we are dealing with. So any inputs of what we are looking at. I have stopped the immunosuppression because we thought of fungal, but before going for further immunosuppression, thinking of anything autoimmune, we have to rule out fungal is what we thought. But clinically, she's asymptomatic. So
Multifocal glioma, but leptomeningeal enhancement. That would be atypical, I think. We thought of lymphoproliferative disorders too, but again, diffusion would be more significant on them.
For HLH, there's no organomegaly. There are no cytopenias. Recent CBP is also normal.
Yeah.
Thrombocytopenia.
Comment from Sridhar, looks infectious, fungal, good possibility, empirically can start amphotericin B.
Yeah, liposomal amphotericin we have started.
You did beta D glucan as well, right?
No, sir, no, we didn't do.
Because galactomannan is just for aspergillus. Beta D
Yeah.
is a pan fungal, right?
Okay. We'll do that. Sure, sir, we'll do that.
Underlying immunodeficiency? I don't think so. Is that right, Prashanti? No immunodeficiency.
We didn't particularly evaluate for it, but we have to consider immunodeficiency because she's immunosuppressed. She has been on steroids, tapering doses.
Yeah.
Is a possibility of doing a brain biopsy? As just
Yes, sir, we are planning for brain biopsy now.
Okay, so I think we're going with infective changes, fungal possible, but brain biopsy is required for the eventual diagnosis. So that is what I'm getting from the chat. Any other
So
inputs?
fungal, can it be without any clinical worsening with such an amount of significant edema?
Possible, but your child is on steroids, no? I mean, immunosuppressant. That could have been masked.
Suppress the symptoms.
Yeah. Dr. Namrata says, please include the leptomeninges in the biopsy. Yes.
Yeah, leptomeninges and the brain together we have planned. Yes.
Okay. Yeah, I think that's what we have for now. So we'll get back to us with the brain biopsy and the findings.
Yeah, sure. Okay.
Prashant,
Thank you.
okay, thank you.
Thank you.
I think I have two more cases from Kim's. Jayant, if you're there. Or three more cases, sorry. Jayant, are you there? Or Prabjot? Two more case.
I think Jayant should be there. So anyhow, this child was a 28 days old child who was referred to us because of persistent focal seizures on one side. So it was basically right focal seizures, and the baseline metabolic workup was normal. And this child also was operated for a hypertrophic pyloric stenosis on day 26 of life. In fact, they presented back to the surgeon with multiple seizures. So this is when the neuroimaging was done, and we were considering a perinatal or a acute AIS for the neonate as a first possibility, considering the focal seizures. The basic metabolic workup for this child was normal. So we just wanted to have your opinion on the imaging and what can be the differentials here.
All right, I've selected images from Jayant. Acute and chronic abnormalities. You can see that the acute or the early subacute abnormalities on the left temporal occipital region, diffusion changes on the subcortical cortical areas out there, and more chronic multicystic and hemorrhagic changes with gliosis in the right hemisphere, also in the left frontal lobe, better demonstrated in the flare sequences. Some degree of cortical laminar necrosis or highlighting of the T1 weighted non-contrast sequences. The basal ganglia are reduced in volume. You can see some ischemic changes or necrosis in the parietal thalami. Again, we have the SAG and the coronal sequences, some social ridging, possibly some microcephaly going out there, and you have these multiple microhemorrhagic or areas of blooming in the bilateral hemispheres, periventricular, deep subcortical cortical regions. And then we have the angio. The vessels of torches, if you see on the angio, it's not typically what we see on the normal angio. I don't have the source images, but yeah. So I'll open the case. Sorry, I don't have any slides for discussion, but thinking of all right, presumed perinatal stroke. Yeah, sorry.
Yes, yes,
Call.
yes. So I think one Sridhar has asked whether we are considering SOMO MOCO deficiency. The only thing was that the acute, we do have an acute stroke also. So that is why we were more inclined towards it being a congenital or arteriopathy.
Arteriopathy, yeah. Call for A, I would agree as one of the differentials. Dr. Bija also has mentioned call for A1. Sulfate oxidase deficiency, at least the cases which I've seen are more bilateral single stage events, or at least here we have some acute abnormalities and some chronic abnormalities out there. Asymmetrical involvement, I've not seen sulfate oxidase deficiency. If either has seen, then yeah.
Okay, and the
My
other
pick on,
thing,
yes.
how's the corpus callosum looking? I mean, is it absent? I felt that I could not visualize it very well.
Okay, I have only one sequence. Like maybe if I scrolled it, it would have been helpful, but I think it is thinned out. At least over here.
Okay.
In my limited experience, this is far beyond what I have seen and what is published about collagen 4-1. This is much too extensive. I'm puzzled by the asymmetry. Just looking at one side, I would also have considered molybdenum and sulfate oxidase deficiency.
Okay. So I think we would consider that also in the possibilities once we are sending the further workup.
Yeah, any other comments? Molybdenum cofactor, yeah.
Yeah, hemorrhage is one thing that we also felt that was something more.
Yeah, Ian, I have not seen hemorrhage as Dr. Bija has mentioned for molybdenum sulfate oxidase.
Yeah. So we thought it is probably old multiple chronic insults and bleeds which are happening. Okay. So I think we'll go ahead with uric acid levels. That has been. Yeah. Okay.
Okay.
And Jayant, if any other questions, I mean, you can add. I think he's not as a panelist.
Anjit, can you make Jayant a panelist quickly? Molybdenum, again, the tortuosity is again commonly seen in collagen-related disorders, connective tissue disorders.
Okay.
Molybdenum, I wouldn't say produces this kind of abnormality on the angio.
Okay.
Dr. Vijay, do you agree or any other?
I also think so that this much of hemorrhage we have never seen in molybdenum cofactor or multiple sulfate oxidase deficiency. I still think that it's a collagen disorder because especially vessels are also tortuous. So this vessel torture began in cutis laxity and all, so it is possible.
Okay. Yeah. Get back to us if you have a gene.
Yeah, sure. We'll get back to you. And then me or Jen.
Okay. Yeah, over to your kids.
Yeah, this was a 34-week baby who underwent a severe perinatal insult. So he required resuscitation for almost 20 minutes. And after that, he was on mechanical ventilation. And clinically, as per the NICU team, it was moderate to severe HIE. He also had multiple seizures, but it was not a status. And he was controlled with only 2 drugs. So MRI was basically done for prognostication on day of life 14. So my very specific questions were that I felt that it was very extensive for it being an HIE. I also felt that the basal ganglia looked very odd to me. I don't know how to describe them. And the brainstem also looked odd. So are we looking only at HIE or we are looking at an underlying abnormality in addition to HIE?
Okay. Again, differentials of the previous case. But before we go on to that, extensive abnormality in the white matter, 34-week, I think now 36-weeker again. Though it's the 33-weeker, you have some abnormalities of the gyration. Extensive white matter abnormality is the deep brain nuclei. You can see that on the T2 sequences are hypointense. The basal ganglia is edematous. You have subventricular edematous changes out there. Brainstem also demonstrates these changes with edematous changes with some degree of necrosis, possibly because of the T2 hypointensities. Corresponding changes of T1 hyperintensities in the deep brain nuclei, the perinephric region. Diffusion abnormalities on day 14 of life without any acute sentinel events, possibly a factor which goes against HIE. Again, you can appreciate abnormalities along the parasocial region, watershed areas, the corpus callosum, the temporal lobe, so the occipital lobe, the cortex out there, and also the deep brain nuclei demonstrating these abnormalities. On the SWA sequences, there is some areas of microhemorrhagic foci. The brainstem is hypoplastic or severely reduced for a 36-weeker at least. HIE, I think, again, should not form this abnormality, the structural abnormality. Corpus callosum is thinned out again. There is corpus callosum involvement. Yeah, so the case, as Dr. Prabjot has mentioned, is this only HIE or is this an HIE mimicker, such as what we discussed as molybdenum cofactor sulfur oxide deficiency, to be ruled out?
So I think the house is also favoring in possibility of an underlying another abnormality. So
No, not at all. This is HIE. Like we see this so often. Patients in 15th day, 20th, the whole brain is melted. This is somehow, maybe the Asian child has that tendency. This is HIE, nothing else.
okay, so what about the brainstem? That got us confused.
See, this is HIE.
I would support Dr. Vivek's opinion. This looks very much like ongoing complete encephalomalacia, which is possible in 2 to 3 weeks.
Okay.
I mean,
You can do the uric acids and homocysteines, but
you may think of legal implications, but I think in terms of practical medicine, this is not an underlying additional metabolic condition.
Okay.
One case per month I see, 3 to 4 weeks patients come with this MRI. They are HIs.
Okay, sir. So the brainstem was also, we felt that, it looked a little hypoplastic. So like
this is Wallerian degeneration.
In the pons, Dr. Vivek, Wallerian degeneration are all the dorsal aspects, I would say.
In the pons, I don't know the answer, but this is going to be CVC. It's like this, the melted brain HIE history is very common and few weeks age. What we see, like you can work out. But
okay. All right. Dr. Mankad says primary diagnosis HIE, but if no, sentinel event screen for molybdenum cofactor sulfur oxidase.
Did you say there was no sentinel event at all?
No, there was, but not in the time of scanning.
Okay.
there was severe HIE, right? There was asphyxia,
There was severe.
resuscitation. Yeah, 20 minutes. Oh,
Yes.
this has to be HIE. Chest compression.
Okay. Okay, Nihaal. Thank you.
Okay, all right. Can you quickly do our case or your case? I think it's
Yeah.
Yeah.
So I just saw the child once yesterday in OPD. One of my neurology colleagues has been managing. So there's the history from yesterday. So 15-year-old, and thanks for putting up the case at such a short notice. So 15-year-old girl, last year, July, she became symptomatic with morning headaches and unsteadiness. By November, December, she was being managed as migraine, chronic headache. Then the fundus was seen, which revealed papilledema, penny drop, and then MRI brain was imaged, and which we will see now. And there was hydrocephalus, so Omaya, and later a VP shunt was put in January, and a second MRI was also done, which is similar to the first one. So mother had died of ovarian cancer, and now this girl surprisingly also in last few months has had a audiometry, which was showing left ear hearing impairment. But she is mobile, but very unsteady. Right side, more cerebellar signs, and left side, mild hearing. But fully conscious, talking, better than before. The headaches are much better, but the etiology is still to be explored.
Okay. The MRI, again, similar pattern what we have seen in our previous cases. Multifocal abnormalities in the flare, parietal lobe, subcortical regions, the white matter out there, some degree of ventricular prominence, but predominant changes in the bilateral thalami, the deep central white matter, periventricular regions, coming down to the brainstem and the cerebellum. Again, edematous changes in the brainstem, cerebellum, some degree of edema in the left temporal lobe out there. And you can see because of the edema, there is paucity of the CSF bits in the cervical reduction, therefore foramen magnum was there. Some degree of inferior tonsil ectopia. Post contrast, do not appreciate any significant enhancement. And then the follow-up, Dr. CSF cells were 2, normal proteins, NMO negative. Queries were, are we dealing with leptomeningeal melanosis, glandular tumor, brainstem glioma, Alexander's disease, or CNS HLH?
Opening pressure was not done. Yeah, I'm just surprised CSF was done because she's still safe because there was so much compression. If we had done the opening pressure, she might have herniated.
I would say brainstem glioma may be unlikely here. Multifocal abnormality is Dr. Vivek. Glandular tumor unlikely. But I'll open the case.
The lack of contrast enhancement is against Alexander's disease. And the swelling of the brainstem is much too impressive for a brainstem Alexander, at least from, I have seen 2 cases confirmed by genetic investigations. And they have also additional supratentorial findings.
Yes, I agree.
The spinal cord is also involved. Did you get those images?
No, I just have the brains.
So the C1 to D6 holocord involvement, hyperintensity, maybe that could be due to the compression in the brain. Yeah,
I think it's maybe a syrinx.
That's not a syrinx. That's an acute lesion.
Okay.
Sorry, what's the story here?
So 6 months history with severe morning headaches and gradual ataxia, July 23. Later was imaged in December and once more in January. And she has had a Omaya and later shunt put in, but she continues to have significant cerebellar signs, even though headaches have resolved with the pressure release.
It looks like a gliomatosis spread of tumor in the brain and the spine.
Mm-hmm.
That's my primary differential. And, you don't even have an acute kind of presentation. So why are we thinking acute things?
Right. HLH is not possible, right? HLH is
I think
not acute.
It is very centered in the thalamus, brainstem. You really need to biopsy this brain as soon as possible. Not that we can do much, even if it's confirmed, but that would be the one thing to exclude given these appearances.
Okay, thanks.
Okay, I think, yeah. Go ahead with the biopsy, I think. All right, let's see. TBC. What does TBC stand for? Tuberculosis? Is that the question? TBC? Sorry.
To be continued next time.
Okay. All right. Spectroscopy not done, Balakrishna. Yeah, okay. Yeah, got it. Spectro, I think not done. Yeah, okay. All right, I think that's our last case. Dr. Ek, if you have a spectroscopy, then let us know. Otherwise, the biopsy results.
Sure.
All right, we'll meet on March 1st, 2 weeks. In 2 weeks' time, please send your cases by 27th. You can email me or put it